Welcome back to the deep dive. Today we're tackling a subject that, well, it demands immediate attention from any specialist clinician, a condition as rapid as it is, frankly, devastating.
That's right. We are diving deep into Clostridial Myonecrosis, perhaps more widely recognized by its chilling common name, gas gangrene.
It's absolutely one of those topics where every single moment counts, and detailed understanding isn't just helpful, it's critical for patient outcome.
It really is, and we're pulling directly from an expert text on this subject today, an excerpt that lays out the clinical picture and the intricate pathophysiology with a depth we rarely get to see distilled like this.
Exactly. So our mission today for you, our listener, is to parse this expert information thread by thread. We're going to extract every critical detail, every clinical pearl, dissect the mechanisms right down to the molecular level, understand the guidelines, look at the controversies.
Really build an unabridged exploration of this terrifying condition, tailored specifically for you, the specialist clinician.
Think of it like taking that dense chapter and just expanding it. Examining every concept, making sure absolutely no vital piece of information is missed in our exploration.
We're definitely aiming for thoroughness over just a simple summary here.
And here's how we're going to navigate this deep dive. We'll start right at the beginning with the foundational elements, the clinical introduction, and how this incredibly aggressive infection presents in a patient.
And from there, we'll peel back the layers to understand the intricate pathophysiology, the deep why behind all that rapid destruction.
Then we'll move into the crucial area of diagnosis.
Mm-hmm.
How do we spot this monster in the clinic and lab?
Mm-hmm.
And following diagnosis, it's all about therapy. We'll cover the multifaceted treatment approach, including surgery, antibiotics, and then we'll dedicate significant time to the crucial and sometimes debated role of hyperbaric oxygen therapy, or HBO.
And we'll look closely at the evidence supporting these approaches, both from the lab bench with animal studies and from clinical experience with observational studies.
We'll discuss the practicalities too, treatment utilization, cost impact, analyze how the evidence is graded, and what the official guideline recommendations actually are.
And finally, walk through the recommended treatment algorithm presented in our source. It provides a really useful framework.
This is going to be a comprehensive, detailed exploration. We're not just skimming the surface, we're going deep to ensure you walk away truly armed with every piece of information this source provides on managing this life-threatening condition.
Absolutely. Let's get started.
Okay, let's kick things off right at the very beginning. When our source defines Clostridial Myonecrosis, what are the key characteristics it emphasizes? What is it, formally speaking?
Well, formally, the source defines it as an acute, rapidly progressive, non-pyogenic, invasive clostridial infection of the muscle tissue.
Okay, acute, rapid, invasive, and non-pyogenic. That last one, non-pyogenic, meaning not primarily pus-forming, that really sets it apart from many bacterial infections, doesn't it?
It really does. Unlike typical bacterial infections that recruit lots of neutrophils and form abscesses with pus, gas gangrene's presentation is different, and we'll see exactly why when we get into the toxins.
Right.
The source also highlights other key characteristics: profound toxemia, extensive edema, massive death of tissue, and, interestingly, a variable degree of gas production.
Profound toxemia. That just sounds ominous. What does that tell us about the systemic impact on the patient?
It means the bacterial toxins aren't just doing local damage. They're circulating throughout the bloodstream, impacting distant organs and systems. It leads to this systemic inflammatory response, often precipitating shock, organ dysfunction. It just rapidly overwhelms the patient's physiology.
So it's a sign of a patient who is critically ill and deteriorating fast.
Exactly. You see that term, the patient is in deep trouble systemically.
And extensive edema. We can picture the massive swelling, but what's driving that fluid accumulation? Is it just inflammation?
It's more than just simple inflammation. This extensive swelling is a direct consequence of the tissue damage and the dramatic changes in capillary permeability caused by the toxins. Fluid just pours out of the damaged blood vessels into the surrounding tissues, increasing pressure.
Which probably makes the circulation even worse, right?
Precisely. It further compromises blood flow, worsening the very conditions the bacteria thrive in. It's a nasty feedback loop.
Massive death of tissue. The word massive here feels key, emphasizing the speed and the sheer scale of the necrosis.
Absolutely. This isn't some slow, gradual process where little bits of tissue die off. The toxins act with, frankly, terrifying speed, causing widespread and rapid necrosis, particularly of muscle tissue. This is exactly why timely intervention is so crucial.
And a variable degree of gas production. The source notes it's variable, meaning it might not always be the first or most prominent sign, but when it is present, it's highly characteristic.
That's right. The gas is a metabolic byproduct. The Clostridia are fermenting carbohydrates within the damaged tissues. Its presence is definitely a strong indicator. It gives the condition its common name, after all. But, and this is important, relying solely on finding gas for diagnosis means you might miss precious time.
Because the other signs might appear first.
Exactly. You need to be aware of the other signs that often precede obvious gas formation, especially that early pain we'll talk about.
So where do these Clostridia come from? The source describes two main origins.
Right. There are two primary pathways for infection. One is endogenous, which is sometimes called spontaneous or atraumatic. This happens when Clostridial spores, which are already present as sort of commensal flora in the body, most commonly the gut, but maybe elsewhere they translocate into tissues when the conditions are right.
Okay, so they're already inside us. And the second origin?
The second is exogenous infection. This is the more, let's say, widely recognized scenario, typically associated with trauma. It happens in situations like compound or complicated fractures with extensive soft tissue injuries, basically, where the wound gets contaminated by Clostridial spores from the environment, like soil or maybe foreign bodies.
And you mentioned the type of Clostridia involved might lean one way or the other depending on the origin, setting us up for a later discussion perhaps on Clostridium perfringens versus Clostridium septicum.
Precisely. As we'll see, Clostridium perfringens is really the dominant species in those traumatic exogenous infections, whereas Clostridium septicum is more frequently implicated in the less common but very serious atraumatic endogenous cases.
The speed of onset is perhaps one of the most frightening aspects of this infection. How quickly can this unfold after an inciting event, like an injury or surgery?
The source states that the onset of symptoms may occur between 1 to 6 hours after the injury or operation. 1 to 6 hours.
Wow.
It just underscores how incredibly little time you have from the moment of insult to the clinical manifestation of a rapidly progressing, potentially fatal infection. This is absolutely not a subacute process.
And the very first symptom. The source flags this as a critical clinical pearl, something that should immediately raise a massive red flag.
It begins with severe and sudden pain in the infected area. And the crucial point here, the real pearl, is that this pain occurs before the obvious clinical signs become apparent on physical examination.
Pain out of proportion to the findings.
Exactly. It's pain that seems wildly out of proportion to what you initially see when you look at the limb or the wound.
That disproportionate pain. It's the kind of symptom that, if you're not thinking of gas gangrene, you might initially dismiss or downplay. But in the right context, it's just screaming for attention.
This feels like a potential board-style question point, doesn't it?
Oh, absolutely.
What is often the earliest symptom of gas gangrene preceding obvious physical signs? And the answer is that severe, sudden, out-of-proportion pain. It is absolutely a critical red flag that should trigger a high index of suspicion, especially in patients with risk factors or after trauma or surgery. You just cannot ignore that symptom.
And speaking of risk factors, for those less common atraumatic endogenous cases, are there specific patient conditions that predispose individuals?
Yes, the source lists several specific predisposing conditions. These include things like colonic and gynecologic malignancies, radiation therapy, chemotherapy, and neutropenia.
Okay, so conditions that either compromise mucosal barriers, like a tumor in the colon, or suppress the immune system.
Precisely. Malignancy in the gut might lead to mucosal breakdown, allowing those commensal Clostridia to invade. Radiation and chemotherapy suppress the immune system, making it harder to fight off any bacteria that manage to translocate.
And neutropenia specifically.
And neutropenia means a severe lack of neutrophils, which are your crucial first responders to bacterial infections. Without them, the body is just incredibly vulnerable.
So putting it all together, if you have a patient presenting with sudden, severe, disproportionate pain, especially if they've recently experienced trauma, surgery, or have one of these specific predisposing conditions like malignancy or immunocompromise, gas gangrene needs to rocket right to the top of your differential diagnosis.
That high index of suspicion based on this combination of history and that key early symptom is paramount. You simply cannot afford to wait for the later, more classic signs to appear.
As the infection progresses visually, what does the skin overlying the affected area start to look like? The source describes a pretty rapid transformation.
Right. In the very early phases, the skin overlying the area might just appear shiny and tense. This reflects that rapid accumulation of underlying edema we talked about.
Oh, yeah.
But then, as the tissue damage accelerates, it quickly becomes dusky, taking on a sort of bruised or purplish appearance, and then rapidly progresses to a bronze discoloration.
Bronze. That sounds quite specific.
It is. That bronze hue is quite characteristic and signals widespread tissue involvement and impending necrosis. It's a bad sign.
And you mentioned the speed earlier, 1 to 6 hours for onset. How quickly can the overall clinical picture deteriorate once these signs do appear?
The source emphasizes the terrifying speed of advancement. The patient can become moribund, essentially on the verge of death within 12 hours from the onset of symptoms.
12 hours?
It's incredibly fast. This isn't a condition where you have days to evaluate and decide on a course of action. You often have mere hours.
What are the specific physical findings that become evident as the infection progresses beyond those initial skin changes?
Well, you may note hemorrhagic bullae or vesicles forming on the skin. These blood-filled blisters are a grim sign of underlying capillary damage and tissue destruction.
Okay.
There's also often a characteristic exudate, a thin, serosanguinolent, sort of watery, blood-tinged discharge from the wound or the affected area.
And the smell. The source uses a very specific descriptor that seems hard to forget.
Yes, it's often described as having a sickly, sweet odor. This distinctive smell resulting from the bacterial metabolic products is another classic clue for clinicians.
And the swelling and edema become quite pronounced then.
Yes, the affected area shows significant swelling and firm, tense edema, often extending well beyond the apparent wound edges. And when you assess the muscles themselves, either clinically, if they're accessible, or more likely surgically, they appear strikingly discolored.
How so?
They look dark red, progressing to black or even greenish, and critically, they are non-contractile, they don't twitch when stimulated, and they do not bleed when cut. That lack of bleeding is a definitive surgical finding of non-viable muscle.
The source also points to a key radiographic sign that can be an early indicator even before things look terrible on the surface.
Yes, tissue gas. On radiographs or maybe CT scans, the gas appears as distinctive feather-like figures spreading along the fascial planes between muscle fibers.
Feather-like. That's a vivid image.
It is. It isn't just generalized swelling or random bubbles. It's gas dissecting through the tissue architecture, creating that unique feathery pattern. It's considered an early and highly characteristic finding of Clostridial Myonecrosis, and a crucial diagnostic clue, often detectable before crepitus is obvious on palpation.
And speaking of palpation, crepitus is also usually present later on, correct? That crackling feeling.
That's right. Crepitus, that palpable crackling sensation under the skin, is the physical manifestation of the gas spreading through the tissues. It aligns with the radiographic findings, but might lag behind them slightly.
And systemically, how does the patient's condition deteriorate as that profound toxemia takes hold?
Initially, you might see high fever and tachycardia as the body reacts, the typical signs of systemic inflammation. But this rapidly progresses to signs of profound shock and multi-organ failure. The sheer volume of toxins just overwhelms the systemic circulation and vital organs, leading to rapid collapse if not aggressively treated. So let's do a quick micro recap of that clinical picture. You should suspect Clostridial myonecrosis in any patient presenting with that sudden, severe pain that's way out of proportion to the physical findings, especially after trauma, surgery, or if they have specific underlying conditions like malignancy or immunocompromise. Look for the rapid progression onset in maybe 1 to 6 hours, patient potentially moribund within 12. Watch for the skin changes, shiny and tense, then dusky, then that characteristic bronze color. Hemorrhagic bullae might appear, along with a thin, serosanguinolent exudate that often has a sickly, sweet odor. Expect pronounced edema. Surgically, the muscles look dark red to black or greenish. They're non-contractile and don't bleed when cut. Radiographically, look for that feather-like gas pattern, which often precedes palpable crepitus. Systemically, patients develop fever and tachycardia, rapidly progressing to shock and multi-organ failure. But remember that disproportionate pain is often your first, most critical warning sign.
Now that we have a clear picture of how it presents, let's delve into the why, the pathophysiology. Our source suggests it's best understood as a, quote, clinical concept, rather than just a strictly bacteriological or pathological definition alone. What does that mean in practice?
It means it's really the interplay of specific conditions in the host tissue and the specific properties of the bacteria, particularly their toxins, that creates this distinct, rapidly progressive clinical syndrome. It's not just about the presence of the bacteria themselves, it's about the whole destructive process they initiate under the right circumstances.
And for this syndrome to be induced, The source specifies two essential conditions that must be present. What are they?
First, you absolutely need the presence of Clostridial spores. These spores are pretty ubiquitous in the environment and often present as commensals in our bodies, but crucially, they are metabolically dormant. They're just waiting.
Okay, so you need the spores. What's the second condition?
Second, and this is critical, you need an area of lowered oxidation reduction potential. Or, put more simply, a low oxygen environment. This is typically caused by local circulatory failure ischemia or extensive soft tissue damage that leads to ischemic muscle tissue.
So you need both the seed, which are the spores, and the right kind of soil, that ischemic low-oxygen tissue.
Exactly. It's the combination of spores and that low oxidation reduction potential that results in low oxygen tension in the affected area. This low oxygen environment is the critical trigger. It allows the dormant Clostridial spores to germinate and develop into the vegetative form.
Okay, so let's picture that. Spore plus low oxygen, low redox, potential aid germination vegetative form. And it's the vegetative form that's the real problem.
Precisely. The spores themselves are resistant and inactive, but the vegetative form is metabolically active. It grows, it divides, and most importantly for us, it produces the battery of exotoxins responsible for the devastating effects we see clinically.
What kind of microorganisms are these Clostridia? Give us the basics.
They are anaerobic, meaning they thrive in low oxygen environments. They are spore-forming, which makes them hardy. They are gram-positive bacilli, and they often have a capsule. They belong to the genus Clostridium, which interestingly includes over 200 recognized species, but only a subset are really clinically significant in humans, particularly for causing gas gangrene.
And which are the most commonly isolated species in gas gangrene cases? The big players.
Clostridium perfringens type A is by far the most common culprit. It's identified in something like 95% of cases. It's often found in combination with other pathogenic Clostridia, but C. perfringens is really the dominant player, especially in trauma.
Are there other species that can cause this syndrome maybe less commonly?
Yes, others can be involved, either alone or in combination, though less frequently. The source mentions Clostridium novi in about 8% of cases, Clostridium septicum in about 4%, and then species like Clostridium histolyticum, Clostridium fallax, and Clostridium sordelli are implicated in 1% or less of infections.
The source introduces a useful way to kind of subdivide these Clostridia based on their primary capabilities, their main weapons, so to speak.
Right. You can think of them in two broad groups based on the toxins they produce and their effects. First, there are those that are primarily toxigenic. This includes the big ones like Clostridium perfringens, Clostridium septicum, Clostridium novii, and also Clostridium fallax. These species produce the potent exotoxins that really drive the clinical syndrome. They also have proteolytic capabilities, meaning they break down tissue, but the toxins are key to the syndrome itself.
Okay, toxigenic is one group. What's the second?
The second group are primarily proteolytic. This includes species like Clostridium histolyticum, Clostridium bifurmentans, Clostridium sporogenes, and interestingly, Clostridium fallax shows up here again too.
So C. fallax has a foot in both camps.
It seems so, based on this description. The primarily proteolytic species are highly effective at breaking down proteins in tissue. They are hemolytic and very tissue necrotizing, but the source implies they may not cause the full classic gas gangrene syndrome on their own, perhaps lacking those really potent systemic toxins from the first group.
Connecting back to the origins we discussed, traumatic versus atraumatic, is there a specific species predominance in each scenario?
Yes, there's a fairly clear pattern described. Clostridium perfringens predominates in traumatic gas gangrene, the scenario associated with contaminated wounds. Clostridium septicum, on the other hand, is the usual microorganism implicated in atraumatic spontaneous gas gangrene, the kind often linked to underlying malignancy.
And the source gives us a clue why related to how well they tolerate oxygen, right?
Huh. It does. Clostridium perfringens is described as not being a strict anaerobe. It can actually grow freely in oxygen tensions, up to about 30 mmHg, and even in a restricted manner, up to 70 mmHg. This relative tolerance might explain its ability to thrive in the potentially less profoundly hypoxic environment of a contaminated open wound, at least initially.
Okay, so C. perfringens is a bit more adaptable in that sense. What about C. septicum?
Clostridium septicum is described as being more aerotolerant than C. perfringens, and importantly, it has a lower infectious dose.
So C. septicum's greater ability to tolerate oxygen and requiring fewer bacteria to start an infection. That makes it more capable of initiating disease in situations where tissue ischemia might be present but less severe than in a major traumatic injury. like in the setting of malignancy or immunocompromise where maybe subtle gut wall changes allow it to sneak through.
That seems to be the logical deduction based on these specific properties highlighted in the source. It can establish infection in environments that might not be as strictly anaerobic as those that really favor C. perfringens.
Now, let's get to the real engines of destruction, the Clostridial exotoxins. The source says more than 20 different ones have been identified. That's quite an arsenal.
It is a complex arsenal of toxins, and many of them are implicated in the local and systemic changes we see.
But is there one that stands out as the most important, the key player?
Yes, the source clearly identifies Clostridium perfringens alpha-toxin as the single most important toxin in the pathogenesis of gas gangrene.
Alpha-toxin. Okay, what are its key properties and cellular effects? This feels crucial to understanding the pathology.
It's a phospholipase C enzyme, and it has potent hemolytic, meaning it breaks down red blood cells and tissue necrotizing properties. At the cellular level, it directly attacks and destroys cell membranes that contain phospholipids, leading to rapid cell death.
And it targets specific host cells, too.
Critically, yes. It destroys platelets, and as we hinted at earlier when discussing the non-pyogenic nature, it destroys polymorphonuclear leukocytes, or PMNs, the neutrophils. This destruction contributes directly to widespread capillary damage and thrombosis, worsening ischemia.
So it's directly killing the host's primary immune cells that would normally be rushing in to fight the infection.
Exactly. It's a potent form of immune evasion and suppression right at the site of infection. And that's not all. Via various pathways, alpha-toxin also causes vasoconstriction of blood vessels.
Which makes the local environment even more anaerobic.
Precisely. It's another nasty feedback loop where the toxin actively helps to create the conditions it needs to do more damage. It's quite insidious.
And systemically, does it contribute to the shock?
Systemically, it triggers a dysregulated inflammatory cascade. It sort of kickstarts this process that ultimately contributes to further tissue injury, mediated by the host's own immune system components, but in a damaging, uncontrolled way.
What does this translate to when we look at the tissue under a microscope? What's the key histopathological correlate mentioned? The signature finding.
The histopathological picture is characterized by profound tissue necrosis, obviously, and something called vascular leukostasis, where white blood cells are basically stuck in the capillaries, adhering to the vessel walls, but they don't actually get out into the tissue. And here is the absolute most critical pathological finding directly linked to the alpha-toxin's destruction of PMNs. There is a characteristic striking absence of polymorphonuclear immune cell infiltration at the site of infection.
The absence of neutrophils. That's the histological signature. If a pathologist sees necrotic muscle with virtually no white blood cells trying to fight it off, they should be thinking gas gangrene.
Precisely. It's a key pathological pearl for pathologists and surgeons looking at biopsy or debridement specimens. That lack of PMNs is a direct fingerprint of alpha-toxin activity in pure Clostridial Myonecrosis.
That's another classic board-style question, isn't it? Which toxin is primarily responsible for the lack of PMN infiltration seen in the histology of pure Clostridial Myonecrosis? Answer: alpha-toxin.
Absolutely a high-yield point. And our understanding of alpha-toxin continues to evolve. Recent findings mentioned in the source show it also impairs innate immunity more broadly. For instance, it inhibits neutrophil differentiation, meaning it prevents immature neutrophils from maturing properly.
So it stops reinforcements from developing.
Kind of, yes. And it also impairs erythropoiesis, red blood cell formation, by inhibiting erythroid differentiation. So it's hitting multiple components of the host's defense and its ability to regenerate red cells, contributing to the anemia scene.
Okay, alpha-toxin is clearly the star player, the main villain. Is there a second important toxin described? A key supporting actor?
Yes. The second important toxin highlighted is Clostridium perfringens perfringolysin O, or PFO. It's also sometimes called theta toxin.
PFO or theta toxin, what's its mechanism of action? How does it cause damage?
It's a cholesterol-dependent cytolysin. Its mechanism involves binding to cholesterol, which is present in cell membranes, and then forming large pores or holes in those membranes. This naturally disrupts the cell's integrity and leads to cell death. It's a direct membrane attacker.
The source references work by Stevens et al. Regarding PFO. What did they find?
Yes, Stevens and colleagues' work suggests that PFO, particularly at high concentrations, is a potent cytolysin itself and also promotes direct vascular injury, adding to the damage caused by alpha-toxin.
And how does PFO interact with alpha-toxin? Are they just independent actors causing trouble, or do they work together?
No, they are believed to act synergistically. While alpha-toxin is considered the primary driver of the myonecrosis, PFO seems to amplify the damage significantly. They're a deadly duo.
What about PFO's effects at lower concentrations? Is it just about forming pores, or does it do something else?
No, this is another fascinating detail. At lower concentrations, PFO actually activates polymorphonuclear neutrophils and endothelial cells. Now,
Okay.
that might sound counterintuitive.
Activation sounds like it should be helpful.
You'd think so. But this activation, surprisingly, promotes vascular injury distally in areas away from the main infection site. It does this by activating adherence mechanisms mediated by PMN-dependent molecules like the integrin CD11-CD18. So it contributes to widespread damage to the microcirculation, not just local pore formation where the concentration is highest.
So the terrifying speed of tissue necrosis isn't just direct cell killing by alpha-toxin. It's also this progressive, widespread vascular compromise, orchestrated in part by these dysregulated host cell responses induced by PFO at lower concentrations.
That's the complex picture presented. It's an interplay of toxins directly damaging cells and manipulating host responses to accelerate tissue death and compromise blood supply over a wider area.
What about the numerous other toxins produced by Clostridia that the source mentioned earlier, the supporting cast beyond alpha-toxin and PFO?
Right. The source characterizes these as ancillary to alpha-toxin and PFO. They aren't the primary drivers of the core myonecrosis syndrome itself, but they are crucial contributors to the overall clinical picture and the severe complications.
How so? What do they cause?
These ancillary toxins give rise to many of the systemic effects we discussed earlier, things like hemoglobinuria, hemoglobin in the urine from red cell breakdown, hemolysis, jaundice, severe anemia, tissue necrosis beyond the muscle, renal failure, and serious systemic effects like cardiotoxicity and even brain dysfunction. They explain why the patient becomes so profoundly sick so quickly with multiple organ systems failing.
So they contribute significantly to the multi-organ failure picture.
Exactly. And importantly, the source notes these other exotoxins also synergize and enhance the rapid spread of the infection locally.
How do they do that?
They achieve this by destroying, liquefying, and dissecting healthy tissue ahead of the advancing infection front. They essentially clear a path, breaking down tissue barriers, allowing the Clostridia and the main toxins like alpha-toxin and PFO to spread rapidly through tissue planes.
With this multi-pronged attack of toxins dissolving tissue and suppressing immunity, how effective are the local host defenses?
Unfortunately, the source states that local host defense mechanisms are effectively abolished when the toxin production reaches sufficiently high levels. The sheer load and potency of the toxins simply overwhelm the local immune response, leading to that fulminating tissue destruction and unimpeded clostridial growth, another one of those vicious cycles.
Is there any natural mechanism the host has to counteract the main player, alpha-toxin? Does the body try to fight back?
There is, actually. The host can produce a specific antitoxin that is capable of detoxifying alpha-toxin, and it can do so within hours after the toxin is produced.
Okay, so there's a defense mechanism, but clearly it's not effective enough in preventing death or severe disease.
Precisely. And this is a critical point highlighted in the source. The infection is so incredibly progressive, with continuous, rapid production of alpha-toxin by the vegetative bacteria, that the patient unfortunately dies before the host's immunity or sufficient levels of this antitoxin can develop.
It's a race against time that the body's losing.
Exactly. The toxin production is just too fast and too overwhelming for the natural defenses to catch up without external intervention to stop that continuous toxin production.
The source mentions a review by Stevens and Titball on the molecular model of pathogenesis, which sounds like a place to go for even deeper detail if one desired. This pathophysiology is clearly a multi-pronged attack by the bacteria using this complex synergistic array of toxins.
It truly is. Understanding the specific roles of alpha-toxin and PFO, their synergy, how they destroy immune cells like PMNs, leading to that characteristic absence, and how they overcome host defenses is absolutely key to appreciating why the treatment needs to be so aggressive and multimodal. Let's do a mega recap here. Pathophysiology essentials. Gas gangrene needs clostridial spores, PLUS low tissue oxygen redox potential, often from ischemia. This triggers spore germination into vegetative forms. Key organisms are C. perfringens, common in trauma, relatively oxygen tolerant, and C. septicum, common in atraumatic cases, more aerotolerant, lower infectious dose. The destruction is driven primarily by toxins. The most important is alpha-toxin. It's a phospholipid C causing necrosis, capillary damage, destruction of PMNs and platelets, vasoconstriction, and crucially, the characteristic absence of PMNs on histology. The second T toxin is perfringens O, PFO, or theta-toxin. It forms pores in cell membranes, causes vascular injury, and acts synergistically with alpha-toxin, possibly promoting distal vascular damage via PMN activation at lower concentrations. Numerous ancillary toxins contribute to systemic effects, hemolysis, renal failure, shock, and help the infection spread by liquefying tissue. This toxic onslaught overwhelms local host defenses. While the body can make an antitoxin to alpha-toxin, the infection progresses too rapidly with continuous toxin production for this natural defense to be effective.
Okay, that's a very clear picture of the underlying mechanisms. Moving back to the clinic, once you suspect it, how do we actually nail down the diagnosis? What's the primary basis?
The source emphasizes that the diagnosis is primarily based on clinical data. Those signs and symptoms we spent time on earlier, the rapid onset, the disproportionate pain, the skin changes, shiny to dusky to bronze, the swelling, the crepitus, the characteristic smell, those are your main diagnostic guides in the moment.
So clinical judgment based on presentation is paramount. What laboratory findings can support that clinical suspicion?
Supporting laboratory findings come from analyzing fluid or tissue obtained from the affected area, maybe from needle aspiration or during initial debridement. You'd look for two key things. The demonstration of gram-positive rods, consistent with Clostridia.
Okay, seeing the bacteria.
And critically, a virtual absence of leukocytes in that fluid or tissue smear.
Gram-positive rods plus very few white cells in the tissue fluid. That sounds like the direct lab correlate of the histological finding of absent PMNs we just discussed, pointing right back to alpha-toxins action.
Exactly. That combination, gram-positive rods and few or no leukocytes, is a key laboratory clue that strongly supports the clinical picture of Clostridial Myonecrosis.
What does it mean, then, if you do find a significant number of leukocytes, a leukocytosis, in the tissue fluid or on the gram stain?
The source notes that the presence of significant leukocytosis usually indicates a mixed infection. While Clostridia might certainly be present and contributing, other bacteria are likely involved as well, and the host is mounting a more typical inflammatory response with neutrophil recruitment to those co-pathogens. Pure Clostridial myonecrosis, driven primarily by that overwhelming toxin production destroying PMNs, tends to have that characteristic lack of immune cells right at the local site. So, quick mic recap on diagnosis. Rely first and foremost on the clinical picture, particularly that rapid onset and disproportionate pain. Support this with analysis of tissue fluid or smear showing gram-positive rods, and critically, a virtual absence of leukocytes, reflecting alpha-toxins effect. If you see significant leukocytosis locally, think about a mixed infection being present alongside the Clostridia.
Okay, diagnosis made or strongly suspected. We must initiate therapy immediately. What is the acute problem the therapy is really aimed at? Our source makes an important distinction here. It's not just about the dead tissue that's already there.
Correct. And this is a truly crucial point for directing effective therapy. We are not primarily treating the ischemia itself or the tissue that is already, frankly, necrotic, although addressing that surgically is absolutely vital. The life-threatening process we are urgently trying to stop is the rapidly advancing phlegmon that's spreading inflammation and infection front caused by the continuous production of alpha-toxin in tissue that is infected but still technically viable.
So the real battle is to save the tissue that isn't dead yet from being overwhelmed by this continuously produced toxin streaming out from the infected zone.
Exactly. You are trying to halt the relentless process of viable tissue becoming necrotic by shutting down the engine of destruction, which is the toxin production occurring in that viable but infected tissue right at the edge of the necrosis.
What is the essential goal of therapy then, given that understanding?
The essential goal is twofold and incredibly urgent. First, it is essential to stop alpha-toxin production as soon as possible. Second, you need to continue therapy until the progression of the disease process has been clearly arrested. Stop the toxin, stop the spread.
And how is this achieved? The source outlines the established pillars of therapy, a concept often referred to as the treatment triad for gas gangrene. What is that triad?
This is achieved by combining three essential modalities working together: aggressive surgery, appropriate antibiotics, and hyperbaric oxygen therapy. This triad, surgery, antibiotics, and HBO, is the absolute cornerstone of effective management for Clostridial myonecrosis.
The triad. Surgery, antibiotics, HBO. That seems like a key takeaway.
Absolutely. If you remember one thing about treatment strategy, remember the triad. All three are critical.
Let's break down each pillar. First, initial surgery. What does the source recommend for that first trip to the operating room?
Initial surgery should be focused and aggressive in terms of removing the source, but perhaps not immediately definitive for complex reconstruction. It should be restricted to opening of the soft tissues or the wound widely and debriding all the ischemic and/or necrotic tissue that is immediately obvious. This removes the initial nidus of infection and the dead tissue that's supporting bacterial growth and toxin production.
What about lengthy or extensive reconstructive procedures or definitive wound closure right away?
The source notes these can and often should be postponed, especially in the very ill, unstable patient. The absolute priority is initial source control, getting the bad stuff out, and getting the other modalities, antibiotics and HBO, on board quickly. Extensive procedures can be deferred depending on how rapidly the HBO therapy can be initiated and how well it starts to show effect in controlling the spread.
How should the debridement itself be performed? What's the guiding surgical principle?
Debridement of necrotic tissue should be performed meticulously and aggressively until clear demarcation between dead and viable tissues can be seen. You need to ensure you are cutting back to tissue that bleeds well and muscle that is contractile, indicating viability. Leave no dead tissue behind if possible.
Okay, alongside surgery, what is the antibiotic strategy?
Antibiotic therapy should initially be broad spectrum. Just as you would for any severe, potentially polymicrobial soft tissue infection before you have definitive culture identification and sensitivities back, you need to cover your bases.
And for specific therapy targeting Clostridia once it's suspected or confirmed?
Specific therapy proven effective for Clostridium perfringens and Clostridium septicum includes penicillin and clindamycin.
Okay, penicillin makes sense. It disrupts the bacterial cell wall, a standard mechanism against many gram-positives, and clindamycin. While it's a protein synthesis inhibitor, it's often thought to have a specific role here in potentially inhibiting toxin synthesis directly, isn't it? Though the source just listed as proven effective overall.
Yes, exactly. That potential inhibitory effect on bacterial protein synthesis, and therefore toxin synthesis, is the common clinical rationale for using clindamycin in addition to penicillin for severe clostridial infections like gas gangrene and toxic shock. It's thought to help turn off the toxin factory, although, as you note, the source here simply lists them both as effective agents. All right, quick micro recap on the therapy basics. The primary target is stopping the rapid spread of infection driven by continuous toxin production in viable tissue adjacent to the necrosis. The goal is twofold: stop toxin production ASAP and halt the progression of disease. This is achieved via the essential triad. 1. Surgery, initial wide opening and aggressive debridement to clearly viable tissue. 2. Antibiotics, initial broad spectrum coverage followed by specific therapy including penicillin and clindamycin. And 3. Hyperbaric oxygen therapy, which is our next major focus.
Okay, let's turn our attention now to that crucial third pillar of the triad, hyperbaric oxygen therapy, or HBO. What is the fundamental basis of how HBO actually works against Clostridia and other anaerobes? What's the mechanism?
The source explains the mechanism at a biochemical level. It's based on the formation of oxygen-free radicals, highly reactive oxygen species within the bacterial cells when they are exposed to high oxygen partial pressures delivered during HBO.
Okay, free radicals are generated. Why is that bad for Clostridia?
Well, aerobic organisms, like our own cells, have robust enzyme systems. Things like superoxide dismutases, catalyses, and peroxidases specifically designed to neutralize these damaging free radicals. Crucially, anaerobes like Clostridia are deficient in these free radical degrading enzymes. They lack the biochemical defenses.
So the high oxygen environment essentially generates toxic byproducts inside the bacteria that they simply can't handle or detoxify.
Exactly. The buildup of these toxic oxygen species disrupts their essential metabolic processes and inhibits their function, including growth and toxin production.
So what is the effect of HBO on Clostridia themselves? Is it actually killing the bacteria directly?
The source is very specific here, and this is a key distinction. HBO is bacteriostatic, not bactericidal, both in vivo in the body and in vitro in the lab.
Bacteriostatic, not bactericidal. So it stops them from growing and multiplying, but doesn't necessarily kill them outright.
That's the understanding presented. It inhibits their growth, multiplication, and metabolic activity.
And how does that relate to stopping toxin production, which we identified as the main therapeutic goal?
That inhibition of metabolic activity is absolutely key. The source references studies, specifically mentioning Gangrene and colleagues, which showed that achieving an oxygen tension of 250 mmHg is sufficient to stop alpha-toxin production by Clostridium perfringens.
250 millimeters of mercury. Can standard HBO treatment sessions actually achieve that critical tissue oxygen level deep in the infected tissues?
Yes. The source confirms that studies have shown that treatment with HBO at 3 ATA, that's 3 atmospheres absolute, pronounced 3 ATA, which is equivalent to 304 kPa of pressure, achieves tissue partial pressures well above 300 mmHg, pronounced 300 millimeters of mercury.
Okay, so 3-ATA gets tissue oxygen over 300 mmHg, which is comfortably above the 250 mmHg threshold needed to inhibit alpha-toxin production.
Exactly. The standard treatment pressure is specifically chosen because it achieves the necessary physiological effect, shutting down that toxin factory at the tissue level.
What about the toxins that have already been released into the bloodstream or are bound to tissues before HBO therapy even starts? Does HBO do anything to break those down?
No, and this is another important clarification from the source. Existing free circulating toxins and tissue-bound toxins are not directly affected or neutralized by the high oxygen levels themselves. HBO doesn't detoxify what's already there.
Okay, but the source notes that these existing toxins are dealt with somehow.
Yes, the source notes that these existing toxins are rapidly detoxified by normal host factors, the body's own natural processes for breaking down and clearing toxins from circulation.
Okay. This is a really important point about the mechanism of recovery then.
Mm-hmm.
HBO stops the factory from producing new toxin, and then the patient's own body has a chance to catch up and clear away the toxin that's already accumulated.
That's precisely the mechanism described. So, if further toxin release is effectively prevented by the addition of HBO, a very sick patient who is systemically toxic from the existing load can rapidly be made non-toxic as their body clears that load without continuously having new toxin added to the burden.
That sounds like a direct intervention on the core pathophysiological driver of the systemic illness and shock. What are the major clinical benefits cited for initiating HBO treatment early in gas gangrene?
The source states quite plainly that early HBO treatment is life-saving. And a major benefit beyond survival is that it allows for less heroic surgery.
Less heroic surgery, meaning less extensive or drastic procedures.
Exactly. It means less extensive or radical procedures are needed, and crucially, it facilitates limb and tissue sparing.
So it helps prevent those potentially devastating life-altering amputations.
Yes. The source implies that without effective control of the toxin-driven spread provided by HBO, surgeons might feel compelled to perform premature major amputations or excisions going beyond the initial essential opening and debridement, simply to try and get ahead of the relentlessly advancing infection. Early HBO helps control that spread, stabilizing the situation and allowing for more conservative surgical management when possible.
And it also helps with surgical planning itself by making it clearer what tissue actually needs to come out and what can be saved.
Absolutely. This is another key benefit highlighted. HBO therapy helps to clearly demarcate between viable living tissue and necrotic dead tissue. This clearer line of demarcation is often visible within just 24 hours of starting HBO therapy.
So surgeons can be more precise.
Exactly. This improved demarcation allows surgeons to be more precise and confident with subsequent debridements, reducing both the number of trips back to the OR and the extent of necessary amputations. You can make a much more informed decision about tissue viability.
Are there other beneficial effects of HBO mentioned beyond its direct impact on the Clostridia and toxin production?
Yes, the source notes a couple of other important points. In addition to its direct antimicrobial effects, which remember are primarily bacteriostatic, HBO also has anti-inflammatory actions, which can help dampen down the host's potentially harmful dysregulated inflammatory response. Furthermore, it can have a synergistic effect with certain antimicrobial agents, potentially enhancing antibiotic efficacy right there in the affected tissues where oxygen levels are usually low. Okay, let's do a mega recap on the role of HBO. The mechanism involves generating toxic oxygen-free radicals that anaerobic Clostridia, lacking specific defensive enzymes, cannot neutralize. This makes HBO bacteriostatic, not bactericidal. Crucially, it stops alpha-toxin production by achieving tissue oxygen levels above 250 mmHg, which is readily accomplished using standard treatments at 3 ATA, giving tissue partial pressures over 300 mmHg. While HBO doesn't destroy existing toxin, by halting new production, it allows the host's natural factors to clear the circulating toxin, rapidly detoxifying the patient. Clinically, the benefits of early HBO are significant. It's considered life-saving and enables less extensive surgery, significantly improves limb and tissue sparing by reducing the need for amputation and improving demarcation between viable and non-viable tissue. It also offers anti-inflammatory effects and can potentially synergize with certain antibiotics. It's a critical component of the treatment triad.
Okay, that provides a solid understanding of why HBO is used. Now let's look at the evidence supporting its use in this context. What do the clinical results in the studies actually show? How strong is the case?
Well, the source begins by noting the remarkable initial clinical results that got people's attention. For instance, Camp, way back in the early days of clinical HBO, demonstrated an impressive 81% survival rate in an early group of 26 patients treated with a combination of HBO, surgery, and antibiotics. That was a striking result for such a deadly disease.
But the source mentions that reproducing those early results in animal models was initially challenging.
Yes, it mentions that as an initial difficulty. Perhaps the early animal models didn't perfectly replicate the human disease state or the timing of intervention. However, subsequent animal studies have provided strong support, showing pretty consistently that HBO substantially reduced mortality, particularly when used in combination with surgery and antibiotics, just like in the human clinical setting. These models have been really valuable for understanding mechanisms and refining treatment strategies.
Let's look at some of those specific animal study results mentioned in the source. For example, Kelly's 1963 mouse study seems important regarding timing.
Yes, Kelly's study, using mice inoculated with Clostridia, really highlighted the critical importance of when you start HBO. In this model, using HBO treatment alone without surgery, immediate treatment started within less than 4 hours of inoculation resulted in only 4% mortality. Just 4%.
Wow.
However, if HBO was delayed to within 12 hours, mortality jumped dramatically to 42%. And if delayed beyond 18 hours, it was 56%. This is stark evidence showing just how time-sensitive HBO's benefit is. The earlier, the better.
And Hill's 1972 mouse study seemed to reinforce that timing aspect.
It did. Hill's study also showed significantly lower mortality with HBO 35% versus 65% in the control group. But crucially, the benefit was again tightly linked to early intervention. The lowest mortality was seen when the first HBO treatment was given within 3 hours of inoculation. If the start of HBO was delayed beyond 3 hours, there was no significant difference in mortality compared to the controls. These animal studies consistently scream treat early.
DeMello's 1973 study using dogs looked specifically at the combination of therapies, reflecting our clinical triad. What did that show?
This study provided powerful data supporting the combined approach we use clinically. Comparing different treatment combinations, the group receiving HBO plus antibiotics plus surgery achieved the highest survival rate at a remarkable 95%.
95% survival in a dog model of gas gangrene. That's impressive. How did the other groups compare?
While antibiotics plus surgery alone resulted in 55% survival, HBO plus surgery alone was 70% survival. And interestingly, antibiotics plus HBO alone was also 70% survival. So while adding either HBO or antibiotics to surgery showed a clear benefit over surgery alone, which wasn't explicitly tested but implied lower, the combination of all three modalities was clearly superior in this model. It supports the full triad.
Holland's 1975 mouse study looked beyond just survival, didn't it? It looked at tissue recovery.
That's right. Holland's study not only showed a significant reduction in mortality with HBO, down to 13% versus 65% in controls, but also looked at the wounds later on. Pathological evaluation after 15 days showed that the animals treated with HBO had significantly less necrotic wound area and their limbs healed faster. This is important because it demonstrates that HBO doesn't just improve survival, it improves the quality of tissue recovery and potentially the functional outcome in the limb.
And Hearn's 1993 study using rats specifically compared surgery alone to surgery plus HBO, directly testing the added value of HBO.
Yes, this study provided strong evidence for HBO as an effective adjunct to necessary surgery. Surgery alone resulted in 62% survival in their model. Adding HBO to the surgery significantly increased survival to 87%.
That's a substantial jump.
It is. And looking at wound healing, the results were even more dramatic. HBO plus surgery showed 94% healing compared to only 20% healing with surgery alone. This again shows HBO adding substantial benefit to surgery in terms of both staying alive and actually recovering function and healing the limb properly.
The source does mention one animal study by mmHg in 1994 that seems less supportive of HBO for balance.
Yes, it's important to note that mmHg observed no significant difference in outcome in animals treated with HBO and clindamycin versus control animals treated with just air and clindamycin. It's included for completeness, showing not every single animal study showed a statistically significant positive effect, though the source does note the finding was NS, meaning non-significant, which could be due to various study factors like power or design.
Okay, so the animal data overall seems pretty supportive, especially regarding timing and combination therapy. Moving to major retrospective clinical studies in humans, how does the human data align with these animal models?
Well, large clinical series reported by researchers like Hitchcock and Hart, referenced in the source, showed high survival rates, around 78% and 81% respectively. Critically, they found these highest survival rates were achieved with initial conservative surgery, meaning perhaps not immediate ultra-radical amputation, but focused debridement, combined with rapid initiation of HBO therapy.
So again, that rapid initiation point comes up in human studies too.
Consistently. Just like the animal data suggested, their clinical results showed that survival declined progressively when HBO therapy was delayed. Time is tissue, and time is life in this disease.
The study by Ertmann and Haveman, looking at a large series of 136 patients over a 20-year period, provided insight into the necessity of combined therapy and perhaps even a dose-response relationship for the number of HBO sessions.
Yes, their extensive experience strongly demonstrated the necessity of a combined treatment approach. They looked at patients treated with surgery and HBO. Interestingly, they reported a mortality rate of 76% in a subgroup who did not receive HBO, or perhaps received inadequate HBO. The wording is slightly ambiguous but implies comparison. This high rate might reflect the severity of their patient population or the era of treatment. But importantly, for those treated with surgery and at least 5 HBO sessions, mortality was reduced by a third compared to those with fewer sessions.
A significant reduction with more treatment.
Yes. And even better, for those treated with 9 HBO sessions, mortality was reduced down to 19%. This data powerfully suggests that it's not just getting HBO, but receiving a sufficient number of sessions that is linked to improved survival. It hints at a dose-response effect.
The large combined series by Brummelkamp et al. And Baker, totaling 409 cases, offers substantial real-world data on outcomes. What were their key findings?
This large data set provides some really compelling findings. They reported an overall mortality rate directly attributable to the Clostridial infection itself of 11.7% across those 409 cases treated with the triad. They also highlighted a critical point about prognosis. All patients in their series who died from the infection did so within 26 hours after starting HBO therapy.
Within 26 hours of starting treatment, that really emphasizes the extremely narrow window where the outcome is decided.
It absolutely does. It underscores the need for therapy to halt the process rapidly. Because if it's not controlled very early, the patient may not survive, even with optimal treatment initiated. Furthermore, their data showed a significant reduction in the amputation rate with the addition of HBO. Only 18% required amputation after initiating HBO therapy, compared to historical rates often cited around 50–55% requiring primary amputation without the benefit of early HBO.
That's a dramatic difference in limb salvage.
It's a huge difference, supporting HBO's limb-sparing benefit observed clinically.
And other studies also consistently showed reduced mortality rates with HBO.
Yes, the source confirms that reduced mortality rates associated with the use of HBO were also shown in other major clinical series by Hart, Hitchcock, and Holland, reinforcing the finding across different centers and time periods.
And Hitchcock's later series reported a particularly low mortality rate when HBO was started very early.
That's right. Hitchcock's later series, perhaps reflecting improvements in critical care alongside HBO, reported a remarkably low 5.1% mortality rate, specifically in patients where HBO therapy was started within the first 24 hours of diagnosis or admission.
So even lower mortality with very early intervention.
Yes. These results strongly reinforce the cumulative evidence across multiple clinical trials and large case series. Recognizing the disease early and applying aggressive, appropriate, multimodal therapy promptly significantly reduces both mortality and morbidity.
So, synthesizing all this clinical evidence, what is the consensus recommendation from experienced clinicians like Hitchcock based on this data?
His recommendation, which aligns perfectly with the evidence presented, is clear. Adequate and operative debridement, appropriate antibiotics, hyperbaric oxygen therapy, and state-of-the-art surgical intensive care support. It's the combination, delivered urgently and expertly in a critical care setting, that yields the best results for these incredibly sick patients. Okay, let's quickly micro-recap the treatment results evidence. Animal studies, like Kelly 63, Hill 72, strongly emphasize the critical importance of timed treatment for HBO benefit. Others, DeMello 73, show the superiority of the combination therapy, surgery plus antibiotics plus HBO, over single or dual modalities. Still others, Holland 75, Hearn 93, demonstrate HBO improves not just survival, but also limb tissue healing and functional outcome when added to surgery. While one study, mmHg 94, was neutral, the overall animal data is supportive. Retrospective clinical studies in humans, Hitchcock, Hart, Ertmann, Havemann, Brummelkamp, Baker, corroborate these findings, showing high survival rates and significantly reduced amputation rates are achieved with early combined therapy that includes HBO. There's evidence suggesting the importance of rapid HBO initiation and possibly a dose-response relationship with more HBO sessions improving outcomes. The cumulative clinical experience provides compelling support for HBO as a vital adjunct, despite the inherent limitations of non-randomized study designs.
All right, moving from the evidence to the practical aspects of delivering HBO. What is the standard recommended treatment protocol or profile for gas gangrene based on the source? How is it actually given?
The standard recommended protocol involves exposing the patient to hyperbaric oxygen at a pressure of 3 ATA again. That's 3 atmospheres absolute, or 304 kPa. Each treatment session or dive typically lasts for 90 minutes.
3 ATA for 90 minutes. And what's the typical frequency, particularly in that crucial early phase?
In the critical first 24 hours after diagnosis and initiation of therapy, the recommendation is to administer HBO 2 to 3 times. So, quite frequently early on.
Okay, 2-3 times on day 1. What about after that?
Then, for the next 2 to 5 days, the recommendation typically shifts to 2 times daily. After that initial aggressive phase, the frequency might be tapered further, perhaps to once daily, based entirely on the patient's clinical response.
And how was that decision made when to stop the HBO therapy course?
The decision to terminate therapy depends entirely on the patient's clinical response. You're looking for clear signs that the progression of the disease process has been arrested. Things like stabilization of the wound, no further spread of necrosis, improvement in systemic toxicity, resolution of edema, and overall clinical improvement. Therapy is continued until those goals are met.
Is there a point where a formal review of the ongoing need for HBO is suggested in the source? A checkpoint.
Yes, the source notes that utilization review is indicated after 10 treatments. This suggests a point, perhaps around day 4 or 5, depending on the initial frequency, where the multidisciplinary team should formally reevaluate the patient's status and the continued need for HBO based on their progress and the overall clinical picture.
Let's briefly touch on the cost impact of HBO. It's known to be a resource-intensive therapy. How is the cost justified in the context of gas gangrene?
The primary cost justification, as stated clearly in the source, is that HBO reduces overall morbidity and, crucially, prevents or lowers the level of amputation necessitated by limb gas gangrene.
So, the argument is essentially that the cost of providing HBO therapy is offset, potentially significantly, by avoiding the much higher immediate and long-term costs associated with major amputation. The complex surgery itself, prosthetic costs, extensive rehabilitation, long-term disability, loss of productivity, and impact on quality of life.
That's precisely the argument presented. By preserving limbs and improving overall outcomes, HBO is viewed as a cost-effective intervention in the broader scheme of managing this devastating and costly condition.
And generally, how long is the HBO course typically used for this specific condition? Does it go on for weeks?
No. Aligning with the typical protocol and the rapid nature of the disease if controlled, the source notes that HBO is generally not used longer than 5 to 7 days for gas gangrene. If the therapy is effective in halting the process, that should become evident within this time frame.
Now, for the specialist clinician, understanding how the evidence for HBO is formally graded is important, especially given the types of studies we've just discussed, lots of observational data, but few randomized trials. How strong is the evidence supporting HBO in Clostridial Myonecrosis according to formal grading systems mentioned in the source?
Right. As we've covered, the evidence supporting HBO comes primarily from that substantial body of animal research and the numerous observational clinical studies case series, cohort studies, which are certainly valuable but are typically considered lower levels of evidence than large, well-conducted randomized controlled trials, or RCTs.
So what about those RCTs, the gold standard for medical evidence? Have they been done for HBO and gas gangrene?
The source explicitly states a very significant point here. No randomized controlled trials comparing HBO to a no HBO control group for gas gangrene have been performed, with the exception of one study.
Just one RCT. Tell us about that single exception. What did it compare and what did it find?
This one study, according to the source, compared HBO therapy specifically to the topical application of oxygen onto the wound, and in that comparison, it found no advantage for systemic HBO over just applying oxygen topically.
Okay, so the one RCT compared it to topical oxygen, not standard care without HBO, and found no difference. Was this study included in any major systematic reviews?
Yes. This single study was the only randomized trial that met the criteria for inclusion in a 2015 Cochrane review looking at the role of HBO in Clostridial Myonecrosis. Based solely on this one comparison study, HBO versus topical O2, the authors of that Cochrane review concluded, quite logically, that there was insufficient data from randomized trials to definitively determine whether HBO was safe and effective for treating gas gangrene compared to other interventions or no intervention.
That conclusion, insufficient data from randomized trials, sounds potentially concerning on the surface for clinicians relying on evidence-based practice. However, the source provides absolutely essential context explaining why there aren't more RCTs and what the clinical consensus is despite this lack of high-level evidence.
This is arguably the most important point to understand regarding the evidence base for HBO and gas gangrene. Despite the lack of evidence from randomized trials comparing HBO to no HBO, the favorable results obtained in those early observational studies we discussed, Bromocamp's high survival rates, the consistent limb salvage observed in numerous clinical series over decades were so compelling to the experts in the field.
Compelling enough to influence practice early on.
Absolutely. So compelling that gas gangrene was included as a Category 1 diagnosis in the very first report of the Hyperbaric Oxygen Therapy Committee back in 1977.
Category 1 status, way back in 1977. That implies a very strong early endorsement, even based primarily on observational data, doesn't it?
It really does. In that initial foundational report, HBO was considered a primary therapeutic intervention when combined with surgery and antibiotics. This demonstrates the strong clinical belief in its efficacy based on real-world observations of dramatically improved outcomes in what was previously an almost uniformly fatal or maiming disease.
And this strong belief, based on observation, leads us directly to why more RCTs haven't been conducted since then, right?
Precisely. Because of these overwhelmingly favorable results seen in observational studies and accumulated clinical practice over decades, conducting a randomized trial that includes a control group that does not receive HBO has been and is still generally regarded as unethical.
The ethical dilemma seems crystal clear. If clinicians and experts believe, based on substantial though non-randomized data, that withholding HBO from a patient with this rapidly fatal, limb-threatening infection is highly likely to result in significantly worse outcomes, including death or amputation, then it is considered unethical to randomize patients into a control group where they would be knowingly deprived of this potentially life-saving and limb-sparing therapy just for the sake of scientific rigor.
That is the absolute core of the ethical barrier preventing high-level placebo-controlled or standard care-only controlled RCTs in this specific condition. The perceived risk to the control group is simply deemed too high by the clinical community, given the devastating nature of the disease and the decades of observational evidence suggesting benefit from HBO.
So, where does that leave us? What is the current consensus among experts and guideline bodies, balancing this lack of definitive RCTs with the compelling non-randomized data and these crucial ethical considerations?
Well, various authors and consensus groups have grappled with this exact issue, and they have generally concluded that the weight of scientific evidence, when you consider the totality of the data types, the animal studies showing mechanism and effect, the consistent observational clinical series showing improved survival and limb salvage, the clear mechanistic understanding of toxin inhibition strongly supports HBO as an effective adjunctive therapy in Clostridial Myonecrosis, despite the lack of large, positive randomized controlled trials confirming it.
The source specifically mentions the 2016 European Consensus Conference on Hyperbaric Medicine. How do they classify HBO for gas gangrene using their formal evidence grading system?
Right. This important conference utilized the modified grade system for evaluating the quality of evidence and the DLPHI system for reaching expert consensus on recommendations. Based on their rigorous process, they classified HBO for the treatment of gas gangrene as a Type 1 recommendation.
Type 1. That means it is strongly recommended, correct?
Yes, Type 1 is a strong recommendation for use.
And what level of evidence did they assign to support that strong recommendation? Was it level A or B based on RCTs?
No, and this is key. The level of evidence assigned was level C.
Level C. What does that signify in the grade system?
Level C evidence means the recommendation is based primarily on consensus opinion of experts, observational studies, or case series. This level C grading is a direct reflection of the ethical barrier to RCTs that we just discussed. Normally, you'd expect a strongly recommended Type 1 therapy to ideally have level A or B evidence derived from multiple positive RCTs. The fact that gas gangrene treatment with HBO gets a strong Type 1 recommendation based on level C evidence highlights this unique situation. The recommendation is driven by the compelling clinical belief, decades of observational data, and overriding ethical considerations, rather than the high-level randomized data, which simply doesn't exist for ethical reasons. It's a crucial nuance in understanding the evidence landscape here. Okay, let's do a final mega recap covering utilization, cost, and evidence grading. The standard HBO protocol for gas gangrene is 3 ATA pressure for 90 minutes per session. Frequency is high initially, 2-3 times in the first 24 hours, then reduced twice daily for 2 to 5 days, guided by clinical response, with a formal utilization review suggested after 10 treatments. The significant cost of HBO is justified primarily by its proven ability to reduce morbidity and, most importantly, prevent or lower the level of amputation, thus avoiding higher downstream costs. The evidence supporting HBO comes mainly from animal research and extensive observational clinical studies. There's a critical lack of RCTs comparing HBO to no HBO due to the widely held ethical concern of withholding a therapy strongly believed to be beneficial in such a severe condition. Despite this lack of level A evidence, the totality of data led to early, strong endorsement, Category 1 status since 1977, and the current consensus, reflected by the 2016 European Consensus Conference, is a Type 1, strongly recommended therapy based on Level C, expert consensus observational data evidence. This highlights the unique situation where ethical considerations prevent ideal study designs, but clinical experience strongly supports the intervention.
Perfect. Now let's put this all together practically and walk through the recommended treatment algorithm or flowchart presented visually in the source. How does a clinician navigate the decision-making process for a patient with suspected gas gangrene based on this framework?
Okay, the flowchart logically begins, as you'd expect, with the initial step, diagnosis. And as we discussed, this diagnosis is based on cultures and CIDOR, perhaps more immediately, the characteristic clinical appearance and supporting lab findings like gram stain.
Right, diagnosis first. Once gas gangrene is diagnosed or highly suspected, what are the immediate essential interventions depicted right at the top of the algorithm?
The very first intervention block clearly shows antibiotics and surgical debridement. These are portrayed as the mandatory, non-negotiable initial steps that must be taken immediately upon diagnosis. No delay here.
Okay, start antibiotics, get the surgeon involved for debridement, then the algorithm moves to considering HBO. Is it depicted as an automatic yes for every patient?
No, the next step shown is a critical decision point. The clinician needs to explicitly consider risks versus benefits for HBO therapy for the individual patient. The algorithm presents a framework for this clinical decision, acknowledging that while HBO is generally recommended as part of the triad, there are specific patient factors to weigh in that risk-benefit calculation.
What specific factors are listed in the algorithm under the heading Increased Benefit situations where HBO therapy might be particularly helpful?
The factors listed as increasing the potential upside of adding HBO are extensive tissue involvement, meaning a large area is affected, an inadequate response so far to just antibiotics and surgery, the infection is still progressing, patients with diminished physiological reserves, meaning they are perhaps older, frail, or have comorbidities making them less able to withstand the infection, and immunocompromised patients. In these situations where the disease is particularly severe or the patient is less able to fight it off themselves, the potential benefit from HBO's toxin-inhibiting and tissue-preserving effects is considered higher.
That makes sense. Conversely, what factors are listed under increased risk situations that might make HBO therapy riskier or perhaps less feasible or beneficial for that specific patient?
The factors listed under increased risk include a high requirement for vasopressors or inotropes, indicating the patient is in severe, unstable shock, where the physiological changes during chamber transport or pressurization could be dangerous. A significant ventilatory requirement, being on a breathing machine, presents logistical challenges and potential risk during chamber transport and pressurization, depressurization. The presence of multi-organ failure, indicating the patient is already critically unstable systemically and may not tolerate the added physiological stress of hyperbaric exposure, and considerations related to the hyperbaric chamber environment itself, ensuring safe monitoring and management during the treatment. These are conditions where the patient's instability or the practical logistics of HBO might pose a significant risk that needs careful consideration.
So the clinician is guided to use this list to actively weigh the potential benefits against the potential risks for this specific patient standing in front of them. It's not a blanket decision.
Exactly. This leads to what the algorithm labels a risk-benefit ratio analysis. Based on this clinical assessment, the algorithm then presents two distinct paths. Either the calculated risk-benefit ratio favors HBO therapy, or the risk-benefit ratio does not favor HBO therapy.
Okay. If the clinical assessment weighing all those factors leads to the conclusion that the risk-benefit ratio favors adding HBO, what's the next step shown in the algorithm?
If the risk-benefit ratio is deemed favorable for HBO, the clear next step depicted is to commence HBO therapy.
And conveniently, right underneath that commence HBO therapy box, the recommended protocol is reiterated. grounding the abstract decision in the concrete treatment plan details.
Yes, exactly. The algorithm reinforces the specific regimen we discussed earlier. Day 1, typically 2 to 3 times, 90 minutes each at 2.8, 3.0 bar of pressure, which corresponds to 3 ATA. Day 2 and Day 3, typically 2 times daily, 90 minutes at 2.8, 3.0 bar. And then Day 4 through Day 7, usually tapering to 1 session per day, 90 minutes at 2.8, 3.0 bar, always depending on the individual patient's clinical response. This provides the specific dose and frequency right there within the overall algorithm context.
So, walking through the logic of the flowchart visually, you start with diagnosis, proceed immediately to antibiotics and surgical debridement, then actively assess the individual patient's HBO risks versus benefits, considering factors like tissue involvement, response, stability, comorbidities. Make a decision based on that risk-benefit ratio. If the ratio is favorable, then initiate the standard HBO protocol. That provides a really clear, structured framework for the clinician facing this challenging emergency.
That's the logical flow presented, yes.
Yeah.
It integrates the initial diagnosis, the mandatory immediate therapies, the crucial individualized decision point regarding HBO based on specific clinical factors, and then the subsequent standardized delivery of HBO if the benefit is deemed to outweigh the risk. Okay, let's try to bring this entire deep dive chapter together in a final mega recap. We've explored Clostridial Myonecrosis, or gas gangrene, in extensive detail. We understand its defining characteristics, an acute, rapidly progressive, invasive infection marked by profound toxemia, extensive edema, and massive tissue death, often signaled initially by that severe disproportionate pain. We've seen its origins can be exogenous, traumatic, often see perfringens, or endogenous, atraumatic, often see septicum, linked to malignant immunocompromise, both requiring low oxygen conditions for spore germination. We dissected the complex pathophysiology driven by potent exotoxins. Alpha-toxin is key, causing necrosis, destroying PMNs, leading to the characteristic absence of neutrophils histologically, damaging capillaries and causing vasoconstriction. Perfringens O, PFO theta toxin, acts synergistically, forming pores and causing vascular injury. Ancillary toxins contribute to systemic failure and local spread. This onslaught overwhelms host defenses too rapidly for natural immunity to cope. Diagnosis relies primarily on high clinical suspicion supported by gram-positive rods and few known leukocytes in tissue fluid smears. Therapy is the essential triad. Immediate aggressive surgical debridement, appropriate antibiotics, penicillin+clindamycin, and rapid initiation of hyperbaric oxygen therapy, HBO. We reviewed the extensive animal and observational clinical evidence demonstrating HBO's time-sensitive benefits in improving survival and dramatically reducing amputation rates, primarily by stopping toxin production via high tissue oxygen achieved at 3 ATA and aiding tissue demarcation. We addressed the crucial context of the lack of large RCTs due to profound ethical considerations, which explains the strong historical endorsement and the current Type 1, strongly recommended. Level C, expert consensus observational data, evidence grading from bodies like the European Consensus Conference. Finally, we walk through the clinical algorithm that guides the application of this multimodal therapy, emphasizing the need for immediate surgery antibiotics, followed by a careful risk-benefit assessment before initiating the standard HBO protocol.
That truly was a deep dive, parsing every critical detail from our source on Clostridial Myonecrosis. For you, the specialist clinician listening, the crucial takeaways are really undeniable. Maintain an incredibly high index of suspicion, especially when faced with rapid onset and that hallmark disproportionate pain. Understand the distinctive pathophysiology driven by those potent clostridial toxins and their specific impact on tissue and immune cells. Remember that absence of PMNs is a key pathological and laboratory hallmark.
And absolutely internalize the fundamental importance of the combined treatment approach, the triad. Aggressive surgical debridement is non-negotiable to remove non-viable tissue and reduce the bacterial load. Appropriate antibiotics like penicillin and clindamycin are essential to target the organism systemically and perhaps locally. And crucially, rapid initiation of hyperbaric oxygen therapy, according to the established protocol, is vital to halt that continuous devastating alpha-toxin production in the still viable tissue at the edge of the infection.
And emphasizing again, maybe one last time, despite the limitations of the evidence from randomized trials, this substantial body of observational data, the clear mechanistic plausibility, and strong expert consensus formalized in guideline recommendations firmly support HBO's inclusion as a primary adjunctive therapy. This acceptance is largely because, in a disease this severe and fast-moving, Ethical considerations effectively preclude conducting the kind of large randomized trials that would typically yield higher levels of evidence, given the compelling observed benefits over decades.
Recognizing those early signs, having that high index of suspicion, and initiating this multimodal therapy, surgery, antibiotics, and HBO when appropriate based on the risk-benefit assessment in the algorithm as quickly as humanly possible can dramatically impact outcomes for patients facing this devastating, rapidly progressive infection. It significantly improves both survival and the chances of salvaging a functional limb.
Let's leave you, our listener, with a final provocative thought to consider, building on our discussion of diagnosis and pathophysiology. Given how incredibly critical it is to stop alpha-toxin production early, perhaps even before those classic but often relatively late signs of myonecrosis like bronze skin and palpable crepitus are fully manifest, could future diagnostic approaches incorporate, say, rapid detection or measurement of specific clostridial toxins like alpha-toxin or PFO directly in wound fluid or even blood? Or perhaps detection of those early host response markers we mentioned, such as neutrophil or erythroid differentiation markers known to be affected by alpha-toxin. Could developing such tools enable even earlier, more targeted intervention, potentially buying precious hours before the full destructive cascade has taken hold and the window for limb salvage begins to narrow significantly? Something to ponder.
We've certainly unpacked this source, thread by thread, detail by detail.
Now, the knowledge is yours. Thank you for joining us on the deep dive.